Good morning and welcome to my video, which is called The Analgesic Adventures of Mrs. Potato, or Epidural Tips for Novices. What we're going to do is start by just running through what the video is going to cover today. In brief, we're going to have a very quick look at why we're talking about epidurals and why we're talking about how to learn how to put them in. We're going to do a very, very superficial recap of the relevant anatomy. Then we're going to cover tray setup and equipment. And finally, we're going to have a little look at a low fidelity model for practicing the loss of resistance technique for inserting an epidural catheter. So, being able to place and utilise an epidural catheter remains a cornerstone of modern anaesthetic practice. Traditionally, the placement of epidural catheters has been taught along an apprenticeship model, very much in the vein of the see one, do one, teach one. Training programs are beginning to recognise that there may be some better ways to teach these. Placing an epidural requires technical skills, organisational skills, applied detailed prior knowledge, and perhaps most challenging of all for a novice, live patient management whilst utilising all of the above various skills in real time. So, let's very briefly recap some of the anatomy. I apologise for the quality of my hand-drawn anatomical diagrams here, but just looking at the bony and ligamentous structures here, we see the vertebral bodies, the posteriorly projecting spinous processes connected by the interspinous ligaments there, and of course below the interspinous ligaments, what we're interested in, the ligamentum flavum. This is the structure through which we place a TUI needle and ultimately a catheter, aiming to find the potential epidural space. So our next diagram here just shows in more detail some of the key structures here. Again, the thick ligamentum flavum beneath the interspinous ligaments. Travelling inward or anteriorly, we then see the epidural space or potential space. Beneath that, the dura, and beneath that, the intrathecal space, which would contain the cauda equina or the spinal cord itself, depending on the level at which we're looking. So, here we have our epidural tray, and we're going to go through the items that are required on this tray. We've got our receptacle for prep. This is of course not going to be poured onto the tray, and we're going to receive some prep in this bowl off the tray when we're ready to prep the patient's bay. We've got spare gauze, we've got our TUI insertion kit and our modified loss of resistance syringe, which is a low resistance but not friction free syringe, unfortunately. We've got a syringe and a sharp 23 gauge Quincke needle for local anaesthetic administration to the skin. We've got a catheter filter, a microbial and bubble filter. We've got a catheter attachment hub, our epidural catheter. This is an 18 gauge. We've got a catheter lock, an epidural catheter lock, and we've checked that that's the same gauge appropriate for the catheter. We've got two different kinds of drapes depending on how you would like to drape your patient. So, just in terms of our prep, I've got 1% xylocaine, whatever your skin prep of choice is, we're going to draw up and have ready for our patient. So that's local anaesthetic for the skin, the blue needle, easily identifiable, there's nothing else in a 5mm syringe. Okay, that's off to the side. So, just drawing up some water. Saline's just as good, doesn't really matter. We want a liquid. Currently, we're doing loss of resistance to saline with this, which is a low resistance plastic syringe. The original technique described a friction-free glass syringe. This is adequate. Then we've got our 2E needle. What we'll do is come up and have a good look at it. As you can see, it's quite a large needle with a 90 degrees aperture on the end. And this is specifically designed for loss of resistance techniques, particularly through ligamentum flavum. Alright, we're going to put our kit together. What we'd like to do to minimise the introduction of air into the epidural space is to flush our catheter. There is a way of doing this so as not to contaminate, even though we've got sterile gloves on. Just by rotating gently, we're going to get the end of this catheter out there. All of the catheter that's actually going to go inside the patient is still sterile in this irradiated bag. Now, we've blocked our hub. We're going to flush our filter at the same time so that there's no air in there, as we see. And now, we've got water coming out the end of our catheter. Okay. This system, the Portex system, simply requires a Lewis slip syringe to unlock that hub. So, hub is ready to attach. There's the catheter block for the end of the catheter. Got our loss of resistance syringe. Catheter's flushed. This is our tray. Most of the disposable trays have more equipment than this in case you're going to perform a CSE or some sort of other procedure or a more complicated procedure, or you have some other requirements. What I like to do with my epidural trays is minimise it so that I know where the next step is and only have the equipment that I actually require on board the tray. So, we've got our tray ready, and this is where we're going to demonstrate the epidural potato, which is essentially an extremely low fidelity model to demonstrate to a novice practitioner the loss of resistance technique and how we can achieve that. This is our patient, Mrs. Potato, who we're meeting for the first time. Now, contrary to popular belief, many people, there is a myth that the potato is really one of the more stoic of the vegetable family, but in my personal experience, I've found them to have extraordinarily low pain thresholds by and large. And so this is not an unrealistic requirement to need an epidural for your potato, depending on what the procedure the potato is going to undergo. Prep. Thank you. For the sake of our demonstration, we're going to insert our epidural on this sterile field. I've got some anaesthetic prep here, which has of course been handed to me outside of the field, and which is, as you can see, brightly coloured. There are a number of reasons for this, but in an epidural or neuraxial block in any circumstance, this is of prime importance. You may find that your epidural, that your site on your patient needs, some patients need more cleaning than others. This particular patient is quite filthy, I must say, but this unfortunately is not that uncommon anywhere in the world, and it seems particularly here in North Queensland. Still, we're going to sterilise our field thoroughly. And we're going to remove our prep from the field. Okay, now, our patient Mrs. Potato is experiencing dysphoria during childbirth and would like adequate analgesia. Mrs. Potato has been pre-prepared with a centroneuraxial cavity to allow us to demonstrate the loss of resistance. All I've done is hollow out a small cavity in the middle of the potato so that there will be a change in texture as we advance our 2E needle. The only provisos are we'll try to assess midline, which is not unusual. So, our patient is sitting steadily. We're going to apply some subcutaneous local anaesthetic for skin analgesia. Patient positioning is everything, and this is no less true, certainly no less true, when you are inserting an epidural into a potato. So that should have had time to work. Now I'm going to assess midline and introduce my 2E needle. Very commonly the 2E needle is introduced at the right angles, but then the bevel should be pointing upwards after we've broken the skin. So I'm certainly within, and in a real patient, hopefully I would be approaching the interspinous ligaments. I've withdrawn the trocar, and now I'm going to attach my low resistance syringe. I've got contact with the patient, and I'm holding the wingtip of my 2E needle, steadying the needle. I'm now going to test the resistance. I might just do that on my side so that you can see. We can probably even get a little look at Mrs. Potato. So I'm going to advance my 2E needle, and I'm advancing with pressure on the plunger of my low resistance syringe. This hand, my non-dominant hand, is steadying the wingtip and maintaining contact with the patient so that I don't lose contact and I don't lose touch with how fast and how steadily we're advancing. So, contact with the patient, advancing with pressure, smooth pressure on the plunger, restricting, waiting for, and there's a loss of resistance. So, clear loss of resistance. What's very common now is to hydrodissect that space with some saline. 4 or 5 mils of saline should be more than enough. I've now got my introducer, so I'm going to insert into the back of my 2E. This 2E is located now through the potato ligament of flavum, and so it's relatively safe to be left alone. The catheter is removed from its bag. It's still irradiated and clean. This has not even been touched by my sterile gloves. And I'm going to insert that into my introducer and feed my catheter. That's feeding nicely, and there's no resistance. So, as the 15 centimetre mark enters into the catheter, I'm going to slowly withdraw my 2E needle while simultaneously advancing my catheter through the 2E needle. 2E's out. I've got hold of my catheter, and 2E needle's off. Okay, Mrs. Potato, you can relax. The needle's out of your back. We do need you to stay still while we affix this catheter so that we don't have to do this again. Now, I had a loss of resistance to saline at 3 centimetres on this patient, and my catheter is currently sitting at 9 centimetres up the skin. What I'm going to do is fix my epidural lock by threading my catheter through the device, cautiously advancing that without removing the catheter from the patient, and I'm going to affix it to the patient's skin. I hope. Although I must say this is the first time I've used the catheter lock on a vegetable patient. Catheter lock's in place. Okay, I'm going to withdraw my catheter now. Commonly we'd like 4 centimetres plus the distance to the epidural space. So 3 centimetres to the epidural space plus 4 is 7 centimetres. 9, 8, 7. Catheter should be in the right location. I'm going to lock my catheter. Now I'm going to connect it. Catheter's now in position. We'll attach our hub. Aspirate. Unable to see any blood or potato fluid in the catheter, and it flushes very nicely. At this point, on a real patient, we will begin the first of our test dose of local anaesthetic. I'm going to apply my catheter and affix a dressing, but essentially the procedure is over. Now let's have a look. She's much happier with her epidural analgesia. So that concludes my video today. Thank you very much for your attention. I look forward to feedback, and I'm sure merciless ribbing from my colleagues.